Great. Good morning, everyone. This is Meredith Gonson. I am the 10 Care Lead for the PCMH program, and I just want to welcome you to today's webinar, Setting the Foundation. The facilitator for today's webinar is Rick Walker. Rick is the lead PCMH coach through Navigant, and he's put together some very informational and very helpful slides for just the PCMH fundamentals of the model. And so I will hand it over to Rick to get it started.
Thank you. I appreciate that. And good morning to those in Middle Tennessee. Good afternoon to those in East Tennessee. As I said, I'm Rick Walker, and I've had the pleasure of meeting almost each and every one of you listening, and it's been a great honor to do so as well. I want to welcome you to our session today, and hope you find it very informative and helpful. Just some quick information. If you're joined by WebEx, here's some to help you utilize your computer. I see many of you are dialed in and logged in as well, so whatever works best for you, please do that. Agenda for today, and you'll notice the time is in Central Time. So introduction, talk about the health environment, the 7 guidelines, and then the foundation for becoming a patient-centered medical home. For some of you, this is familiar. For others of you, it's the first time that you've really delved into this. And hearing some of what the coaches have already been speaking with you about, some of what you've been working with, those of you that have Blue Cross folks that come out with us, or in other times we're not out there. Again, good information, and you'll see how it ties together, and we've been working through this. Before we go any further, though, I want to thank a few people for making this happen. Of course, Carly and Meredith at the state for making the time and setting this up. I'd like the coaches, Tina Owen, Pamela Hicks, Shonda Davis, and Patterson throughout the state for working so hard to help you in achieving the goals that you want to achieve and becoming patient-centered medical homes. I also want to thank Christina Roddick. Many of you know her through the setting of the assessments and through the courses. She is the backbone of this and makes things happen. So, Christina, thank you so much for making this happen. And then to all the practices, thank you for what you do each and every day throughout the state in providing the best health care possible for our fellow Tennesseans and for allowing us to come into your practices and to be a part of the organization. Introductions to this series. I have at least 3 of these set up over the next couple of months, talking about the foundation of becoming a patient-centered medical home. And really, it's about transformation, not about checking boxes. I know we've all been through JO and now the Joint Commission or AAA, HC, or PCMH, or even the acronym, and we've been through it a couple of times. But now, the way these new standards are, and we'll get into it a bit, it's really about transformation and transforming our practices into becoming those patient-centered medical homes. For those of you that are already recognized through NCQA, you know that it was filled with check boxes. There are as many now, which is much better, and it truly is about transformation and that continual improvement process. I'll discuss that in a little bit here. I also recognize that the guidelines that we're utilizing, the standards, don't read from page 1 to 60 or from concept 1 through concept 6. It's like putting a puzzle together. And I saw that in the coaching plans that we developed. It was about what were your needs most pertinent to you at that time. And that was our coaching plans were developed. And as we get into this now and get to know your practices as well, it changes, and you can see that it just doesn't work starting at page 1 and trying to work through. But we guide those standards and make this happen. So we're going to show you how these concepts fit together, where a tune starting point might be, and then appropriate ending as well. And hopefully this gives you a better understanding of the big picture goals of what patient-centered medical home is, and not just a bunch of boxes that you need to check to be recognized from NCQA. So like I said, our goal is to break this down, put them together in a way that makes sense for you. And as we talk here today, some of this will make sense right now for you, and others we're working in a different area on different items, areas of focus, and that's okay. That's what's fantastic about this, is we start, it's a start for each practice. So it's going to go on for about an hour. We'll talk for 30 to 45 minutes. We'll go through this. Time for questions, comments at the end, but please, I'm going to ask for input throughout. Anytime that you want to give a suggestion, say something, have a question, chime up the chat box, and we'll make that happen. And we also want to create a sense of team and collaboration across the state as well, with your regions and across the state, that we're working together and provide the best care possible. So we'll identify the NCQA PCMH 2017 criteria. For some of you know them as factors. The language has changed. Several things has changed. We'll get into some of that. And some of it we won't. We'll have time to review everything throughout these sessions, but we'll make our best effort to on those important things. These will be recorded, and I believe they'll be posted to TennCare's website. If that's not correct, we'll figure that out and get you the right information as to where that is. And we'll get through here. As we go through the guidelines, you're going to learn more details from concept to criteria to competency, and we'll cover the criteria that are integral to the big picture here. You can see on the screen there, if you want to chat and have something to say, if you do the send to box, just on everyone, that way I'll be able to see it. If you click on everyone, only Stina will see it. She'll get it to me, but just to make it easier for all of you. In order to remain anonymous, that's fine, but to offer you the opportunity to interact. Dive in. So anyone in healthcare for more than a year knows that it is a shifting environment, and the patient-centered medical home is an approach. It's a model to provide patient care in a way that enhances outcomes, so we have better outcomes for our patients. We're better stewards of our time and our resources, and our resources can be financial, again, time, equipment, all things that go into there, and hopefully as well create a better environment for you, the folks in healthcare practicing, because you're working hard, you're doing a lot, and a lot has been asked of you, and here we're asking more of you, but our goal is that being asked of you to be there with you to help make sure you can get through this journey. And you can see this comes out of the joint principles of PCMH way from the beginning in 2007. So if you may be aware, PCMH started American Association of Pediatrics way back in 1967, and it was basically a central location for a child's medical record, and it was focused on children and youth with special health care needs. In 2002, the definition to home base for child medical and non-medical care was expanded, and today, of course, it's all about the patients. It's a partnership with the patients, the family, the care provider, the clinical and non-clinical nursing staff, specialists, and the community. It's all of that rolled into one. Of course, it has their own take on it. The American Academy of Family Physicians and the American College of Physicians have their own definitions as well. But ultimately, it's getting to the end goal. So why does PCMH matter? Why are we doing all of this extra work? That's a good question. And we've had that, and that's okay. I love those kinds of questions. And and be able to have that discussion. So medical homes, as you know, foundation for the care system, hopefully to achieve the triple aim from IHI, the Institute for Healthcare Improvement, of better quality, a better experience, and better. And see, now we're in this the service type environment. We're moving to this value-based care environment, and it's a challenging transition for everybody. My impression of it is we're kind of stuck somewhere along that continuum where that arrow is there, because that's the big jump, and there's a lot of uncertainty on the other end. So hopefully through this transformation, through PCMH, incorporating these ideas, these concepts, this methodology into our practices, it makes transition easier. And what's nice about it is that everyone is involved in this, not just the care practices, but the state, those other CMS, all of those folks are trying to make those change. There's a lot of benefits of the medical home, and we talked about this: better quality, a better patient experience, continuity, that's huge. And then prevention and disease management, as opposed to routinary medicine where someone's sick and then we take care of them and present with that. So, studies show lower costs, reduced emergency department visits, hospital admissions, and reduced disparities in care and lower rates of provider burnout. And that's huge. Providers have had so many things just relapse in addition to their care, and hopefully it can make that better for them. As we move from fee-for-service, volume-based healthcare system to pay-for-performance, the patient-centered medical home helps support practices and foundations that need to be successful. Important to know that we realize we're currently facing many challenges. There's just being made as we speak. As I said, we're living somewhere near that red arrow, and making that jump is a big step in healthcare. I know if we carve out the time, attention, resources to setting up processes, we asked a lot of that of many of you to, you're doing a lot of the work already. It's the documentation and the evidence that we're asking you to create and put together. And many of you are doing amazing jobs, or you've already had it and it just is something you haven't looked at in a while, or you're revising that. We'll get into that here in a little bit. But ultimately, we're hoping for a lot higher quality outcomes at much lower cost. And again, just an example of what this looks like, current model to the future model, hopefully gives us an idea of what the aim is. This might be years down the road. Have already made a lot of transitions toward this, and I think it may be sooner than we anticipate as well. Regardless, though, of the fact, it's important for all of us to be on the same page about where we are and where we're heading, and I hope this gives you a good idea. Right now, let's do what we'll talk about. NCQA PCMH 2017. So many of you have been involved with this, some from the beginning in 2008, and then 11 and 14. Language has changed. The way things are done has changed, and we won't spend a lot of time on that. We're working those processes, and if we're not, and we're doing a good job, please let your coach know so we can make sure that we're focusing on this. We have 6 concepts within NCQA PCMH that were previously standards. As I go through, I'm going to refer to them by their acronym from here on out. So you can see care and practice organization, knowing your patients, and so on. Competencies below those concepts previously referred to as elements are the subsection, and then there's criteria under them. And those are the things that we are working on. And you're well aware, there's core criteria that everyone is required to meet. 60 elective criteria points, and you have to complete 25 of the electives. My recommendation, and what I've been suggesting to the practices I'm working in, is that we identify at least 30 of those, maybe 35, just as there is a possibility that what we provide to NCQA isn't meeting the intent of that specific criteria, and we may have to have some additional. I'd hate to see somebody just have 25 and then for a reason we get to our deadline and we're supposed to find something else. And then there's a new online platform called QPass. I believe all of you have registered in this already, and it was interesting, but we grew it, and I think a little easier than some of the old ways of doing things, but here we are. And here's a couple of websites. If you're not already familiar with them, there's the NCQA website, and then those that are 2014 recognized. This link will talk to you about the difference of what's going on, some of the terminology that is going with it. Staining guidelines, they're meant for practices that have achieved level 2 or 3 recognition already. Things are streamlined now, and there will be changes that come out each year from QA, and this is something that routinely has happened over the last years. So paying attention to those. You're checking your NCQA site, you're keeping up to speed with those, and you're getting the emails from NCQA. Those of you that are 2014 level 3 recognized, you get to bypass a lot of this and go directly to annual reporting. I won't get into that here, but it has been streamlined for you, and reporting begins 30 days before expiration of your current recognition cycle, and that means your anniversary date for your annual reporting. If you go to that website there, that will get you to the information that you're for. We said that it's about setting the foundation today, identifying and laying in place criteria that anchor the rest of the project. Typically, we're doing corners and the outside of the puzzle. That's typically where I start. It's easiest for me to do that, and that's the approach we're taking. Well, you know, we're building that foundation and going in there. So are the criteria that we will speak on today. A moment to check those out. Notice I don't read slides. I think you're well educated and able to read and can handle that. Saves a lot of time as well. And I can read in slides. I'm sitting in the audience. We'll dive in here. Let's start with that clinician lead, designated clinician lead of the medical home and a staff person to manage the transformation. See down there in the right-hand corner, I've got team steps listed there. This is where that's derived from. The Department of Defense has utilized team steps for years. There's about 25 years of research that's gone into this. If you're not aware what Team Steps is, it's an evidence-based set of teamwork tools, and it's aimed at optimizing patient outcomes. And the biggest way to do that is through improving communication and teamwork skills among healthcare professionals. Go to the Agency for Healthcare Research and Quality, ahrq.gov. You find out all sorts of stuff on Team Steps, and there's training that they offer there as well. But I put this because the physician lead really needs to believe in work. They must want to do it consistently and be working to improve the practice and to improve the triple aim: help your patients, happier patients, lower cost healthcare. In order to do this, we've got to create time. We've got to carve out time, create innovative thinkers, be eager, get us excited. New practices that they have some provide input and some physician input, but they really don't have a physician lead out there, and they know that's challenging for them. But I think, from my experience already, is that's such trust and faith in the folks they have running their organizations that they know, and it appears that they've given them the latitude to take on, and they are the PCMH leads. But I highly recommend that you have a physician lead in your organization to help you with this, because let's face it, providers relate to providers, and if you have a provider that's leading the charge, that's to get the other providers on board. Providers need to delegate as well. You know, they're not the ones that have to do all the work, especially this clinician lead. And as we've discussed in our conversations about the clinical staff working at the top of their license, I always reiterate this includes the providers as well. There are things that only providers can do, and have them focusing on those things, and the clinical team doing clinical team tasks, the clinical team doing those tasks. Make sure everyone is in lane, but working together and making that flow happen. And we'll talk about that in a little bit here. PCMH coordinator, those two together are the linchpin. We need someone to coordinate all this, to implement it, to lead those PDA cycles, plan, do, study, act, to delegate as well. They didn't have to be doing all the work either. You know, that's easier said than done in some cases, just because the size of the staff or the practices. But to figure out how much time they need, what's their qualifications, you know. But this is the driving force for change right here with that clinician lead. Those two right there are going to make it happen in the practices. Leadership skills. Those are other areas that we can provide in as well, outside necessarily PCMH. It's all a part of it, but that's part of quality improvement and team building, and those are areas that we can help you in as well. Or I just recommend getting involved in some leadership training on your own, and then having good organizational skills. And not the job for the weary, as many of you know. And the biggest thing with these two, the requirement is it has to be documented. There has to be documentation of who these players are, what their roles are, what their, I can't word I want, but you know what I mean, because we've talked about this. But having it documented somewhere and was implemented so that when you submit for recognition, NCQA knows who you're looking at and who they are and what their roles and responsibilities are. And that as well. Hiring staff, I think a lot of you are really doing well at this, at least from the experiences I've had and the conversations I've had. And that's across size organizations from my experience. This is one of the hardest thing practices, especially in small ones, but getting folks involved. If you have a leadership team or a corporate team, of course, you have that overarching decision-making, implementation, but getting those folks from clinical staff, the nursing staff, billing, front desk, you think about the areas in your practices, getting them involved in developing and creating those improvement activities, and then evaluating them as well, because they're the ones implementing it. To be an example, I spent 20 years in the Air Force. We sent this young lady. She was a lower enlisted rank, E3. I won't go into detail. She was administrative technician. She worked the front desk, did records, all of that stuff. We sent her to Washington, D.C. as we were talking about implementations being made because the Department of Defense does use and follow the NCQA PCMH model. And she was by far the lowest ranking individual in that audience of officers, general officers, and they were discussing front desk. And the things they were discussing, the things that they had no idea what they were talking about. And this young lady stood up and in the midst of that group spoke up that, and of course in a very respectful and distinguished way, but she was there living it daily, and the things that they were talking about didn't make sense to her, and she was able to shine the light in that area and tell them from living it, not just from her perspective, but from the patient's perspective as well. And we received nothing but accolades from her. So I tell you that story just to give you an example of you never know who has the great, who has the experience, who's been thinking about something for so long that, and they just maybe didn't feel they had an avenue to explain it. So I highly recommend that you look at that. You accomplish quality improvement in a bubble. It seems to maybe have taken effect, but it doesn't always work that way. And your staff, and many of you know this, they have buy-in to it. The change is much easier. If we send that message explaining why we're doing these things, what the outcomes are, just like we do for any type of contract or even with this program to your corporate level folks, what return on investment for this? What's on the other end? I'm telling you, you'll have a more involved staff, and many of you already know this because you do and are living it. Staff, team-based care, there's more components to this. You make staff feel like they're part of a team. They're on things, they're providing feedback. Then again, the documentation, put it into the structure. Staff knows what their role is, know what the expectations are. As many of you have seen Simon Sinek's why, what is your why? They understand the why, including how it's related to quality improvement, how it's related to patient-centered medical home, and it gives them a better idea and a concept of what the patient-centered medical home is. And ultimately, it's down to culture. What is the culture of your organization? What is that communication like? Is your org chart identify who's who, who's where, who's what lane are you in? Are job descriptions, do you have job descriptions? Are they up to date? Do people understand what they are? Do you review your job descriptions with your folks over a year, 2 years, things of that nature? For every practice that's different. I'm not telling you that's what you have to do, but these are just some things to think about. And I want to give you a quote from George Bernard Shaw. His single biggest problem with patient is illusion that it has taken place. And how is that? Many times we think we committed something or we communicated it effectively, but the receiver didn't receive that or that message. So making sure we take the time to have communication and setting the expectation and then affecting those things so people understand what they're doing and why they're doing it. Structured communication, as we get into this is specifically talking about the clinical team and their communication, their patient care coordination. As you can see by the screen here, this should be a video that plays, but unfortunately we had technical difficulties and we won't be playing that. Some of the ways we can do this, some are doing it or implementing it, are huddles, a morning huddle, an afternoon huddle, an evening huddle with the provider and the nursing staff, with the whole team. It just depends on what your makeup is like and most effective for you. Another way that they do it, because not all practices, huddles are the best form of structure. structured communication for them. So there's practices that utilize their EMR for structured communication. They send tasks to each other. They utilize email. There's other folks that print out the schedules. The nursing staff reviews them, writes the information down, gives that to the provider. The provider makes their comments and notes and get back to the nursing staff. The nursing staff communicates with the front desk. Those are all acceptable ways of structured communication. You know, if anyone out there would like to share something right now, structured communication that they have, don't be shy. I was going to interject, and you don't have to hear me. Anyone share anything? You can read or on a computer. I'll have Christina's going to hate me for this if she do it. I don't know. Have everyone taken off of mute, and anyone wants to share something, just state your name, who you're with, and what it is. You get Christina?
I think I can do that. Let me chat.
I'm one to push boundaries to get told otherwise. So, all right, you're all off of mute, so not everybody at once. But if anyone has anything they'd like to share, please feel free to do so.
We're not muted.
You're talking while I'm talking. Now's a good time to stop. All right. All right, the old adage that silence constitutes consent, or that nobody has anything. So since everyone was silent, yeah.
Message actually that I received privately. How to do proof of huddles? We do morning huddles and use the schedule to document what is needed. Sorry.
Yeah, question. So a couple of ways you do that. One is, but it's a fact, you have to have a documented process of how you do huddles. It can be simple as a paragraph or a policy. So develop, it can be a one-page document, how your clinical staff has structured communication. And there are several ways to show evidence of that. One is some folks have a huddle sheet, which is something they create and they write down their information. It has to have a date on there. And what we've been doing is saving those, sending them into the computer and putting them in a folder for session. An option, and this is coming straight from NCQA, could video your huddles and show evidence of that happening. Or you're on your face-to-face with your viewer through the internet, you could actually show them a live huddle happening. So there's several ways that you can get evidence of that, but you will have some type of documented process on how your organization performs.
Hey, Rick, I didn't receive anything else, and unless anyone has questions, I'd put everyone back on mute, except you, Emily, and Meredith. Just give me 1 second.
Muted.
Changes. Now it's really focused on what's best for the practice. How do we document? How do we do these processes? You're not being told that you have to huddle, that it has to be every morning, that it has to do this. Because you have effective communication and you know it's effective because you see it happening and you see being implemented and taking place, then that's it. That serves a purpose. And if you have further questions on documentation, please get with either myself or one of the coaches, and we will delve into that. A great video that I can't show you, but it's a circle team here, and they were talking about pre-visit planning. So that step before the huddle even, and looking at your usual out a day or two, and realize that not everyone can do that. But you all know what you can do and how you can implement things. So these are just ideas that throwing out there. But look at your folks a couple days ahead of time, knowing what labs they need, what orders they need. If you have referral managers or care coordinators, they're a part of that clinical team too. Bring them in and making sure that if they're in for a follow-up from having gone to see another specialist, making sure that documentation is in there. Make sure you have what you need so you have just efficient, best-sized appointment for the patient and for the staff. We've done many of the practices about standing orders that give the nursing staff tools that they need to function independently and work at the top of their license and being efficient. And many of you have some excellent standing orders in place. It was something I've utilized in my career as well. As medics in the military, we were able to function at a very high level and patients in and get things done because we're operating at the top of their license, and it creates efficiency. Some people aren't comfortable with that, and I get that. And this is, again, what's for your organization. You do that. Then another thing you can utilize is a debrief after a day, after a week, or after a particular item that, maybe something that's out of an ordinary if you do procedures or whatnot, or after an incident, unfortunately, is having that debrief. But this example here was a successful surgery, and they talked about what went well from each team member's standpoint, and then what could have gone better, or what could we have done differently to make it go better. So asking those questions and delving in, you will get answers, and it will be things that really, I think, can make a difference in your practices. Sharing data with staff. This is a touchy one sometimes because it talks about the clinical performance and the provider's performance as well. So is information being shared with the providers? Do the providers know where they're at? How about their teams? What data are you sharing the entire staff? And how are you explain it to them in a relevant way? Because as you can see, not everybody's clinical, even though we all know these terminologies. I'm amazed how many people that work in primary care don't know what PCMH is or what a patient-centered medical home is, and those things that we're to overcome here. But those are good ways to get folks involved through these briefings, asking how their patients are, their providing an avenue for them to provide information back to leadership or to quality improvement teams or whatever they have working. And then, that old adage about an Opendoor Policy, that means something different in each environment, but ensure that the staff is aware of what's going on. Because let's face it, we're all stakeholders at somewhere along the point, and the more information that we have pertinent to what we're doing and we understand it, the better we can do our job, and in our case, the better care we can provide for our patients. And this is for how to get practices involved with but you take this and quality improvement. You can take this and apply your practices to your sites as you see necessary, and be creative with it. This is another area that our coaching staff can do in and give you resources, tools, ideas. We can come in also and do quality improvement sessions with your staff if that's something you like, whether it be your leadership staff, your practice managers, or your entire staff, or those individual sections. So creative and utilize us. We're here for, and we want to provide you with helpful, useful information and tools to make your practices that much better. A little bit about this, hey, did everybody get the message? We thought everybody got the message, but as we can see, not a message in this case. And so many times that happens. Reference from team steps, but that's always a good place to go back to. There's a lot of good things in there and come out of it. There's importance in ensuring that all the staff are on the same page of how the practice functions and about what their roles are. Again, use a military example, and I've shared this with several folks, but you imagine I'm sitting back in here in Tennessee or in South Carolina working in a clinic, and what's an Air Force, Army base or whatever, and there's a war going on. What impact am I having sitting here? Well, you're providing medical care for our warfighters, for those folks that are engaged in operations, preparing them to go, them when they return. And one of the biggest things that I remind my folks about a lot is that family members are here. They're down range, focus on what the thing I wanted was a family member complaining to their employed about some negative experience at the hospital. That was the last thing I wanted. And to get that's how we into the big picture. That's how important our role is in this whole thing. So if you can take that time and share that through job descriptions, through organizational charts, through meetings, showing people how.
This is Chris. I just want to stop you really quickly. Our screens have here, so we can't see your presentation.
Okay.
Is there something you want to do on your end to fix that, please?
If you could just go to the quick start and share your screen again. That should solve it.
Shut down. I have the quick start, Christina. Is that okay? Awesome. Now the picture that makes sense. All right.
I wanted to send in just give you a little bit of a time check to let you know that we have 14 minutes left in our time. Thanks.
Yeah. Some things to consider in developing your organizational charts and job descriptions. And if you're having difficulty with this, we have access to a lot of things we can help you with. Staff involved too. Have them write down what it is they do, what it is they think they do. And examples, reach out to each other and find out, what do you have for this type of role, care coordinator's role? What do you have? How do you explain these things? So, and then we make sure that at some of this documentation they understand how the role and responsibility supports the PCMH function, and that can be simple as adding a line or two to a job description about how it's incorporated into the PCMH. about doing surveys for our staff, being a feel for what the culture, the climate is, get an idea of what they think is going on in their, how effective your communication those are. So that's something else to consider is, have you conducted a staff survey in those years, 5 years? You've had some organizational change, taken on practices or not. And then having patience. I know this one's a scary one and a dicey one, and we've had some conversation about it, but gets involved in of our organizations. I can't which practice it was, but there was one practice that I spoke with, and they had an idea for reassuring their whole facility. And some of the patients involved, and the patients thought the facility was fine the way it was, and they had some other ideas. So it took them a lot of money and a lot of time and do this reconstruction, but yet they were able to make changes that were specific to the importance of the patients. So there are some organizations out there that are just successful, and one of the things that we've gotten some feedback on is doing some collaboratives about developing patient advisory groups or committees, or how do we get the patients involved more in these things, and how do we control it without the conversation being about the color of the walls or what television stations on in the. So there are challenges to it, but there's some organizations that are doing it really well, and we're reaching out to them to get some feedback. Many of you do surveys, but that's a good way to get some quantitative data. There's plenty of ways to do surveys. If you haven't done one in a while, it might be something you want to consider. You're familiar with the CAPS survey. It's very long, but you can utilize the whole thing. You can take questions off there, and really we're looking at the patient experience, things like timely care, how well our providers and medical staff communicates with the patient, care coordination, things like that. And we can help you in developing those if it's something that you haven't done or want to delve more into. But these, as you can see, it's a core requirement with NCQA. And quantitative information, lessons and challenges you find by doing these. How do you do these surveys? Who are you surveying? Everybody, the certain group of people? What kind of questions are you going to ask? How often are you going to do this? Be careful, because we get surveyed to death. We get all kinds of surveys. We're going to have a survey for this. Ask you what you thought of this and provide some feedback for as well. And again, we're going to give you another survey, but we appreciate this because, again, this is cool. We want to provide you the best information possible. But at the end of the day, as Anne Morrow Lindbergh said, good communication is as stimulating as black coffee and hard to sleep afterwards. What today was really about communication with other patients, the team, the staff, all throughout that, and setting a foundation of effective, solid communication within those we looked at in those criteria help achieve goals of this PCMH. All right, so that is all I have on the so let's open it up to any further questions, comments, concerns. Steve, how do you want to do this? Same way we just did?
I think what would be best we've done in the past is if you have a question, please utilize the chat box function. You just have to click that icon. It'll illuminate blue. And the send to drop-down box is sent to everyone. And just go ahead and type your question in that box. And
all right, my screen I see here because I had that up and I can't find it now.
received any questions in the chat box.
All right. Anyone have an example of they utilize for successful, effective, structured communication, the kind of difference it's made in your organizations, in your daily workflow? I'll keep us silent for too long here.
Okay, we have one message. Victoria Mathis, she said we utilize eye-to-eye patient summary sheets to pre-visit plan and set up huddles.
Excellent. They're utilizing products that are already out there that folks have already and been successful. Thank you for sharing that. I know you're modest, and some of you want to go eat lunch, and some of you need to get back to work.
Rick, I do have one message that I just received. Care coordinators review the schedule a day ahead of time to check for gaps in care.
Awesome. That's a great use of folks and getting them in there. I believe that's from Mary. How has that been for the patients, for the staff, and has it streamlined your appointments? If you can let us know there in the chat. And anyone else want to share? All right, I won't make us sit here in silence any longer. Appreciate all of you calling in, dialing in, come via the computer. I know some of you have asked if this would be available. Make those available if you want as well. This has also been recorded, so you come back and check it out. Again, I thank you all for your time and what you're doing and allowing us again to come into your organizations and work with you. And with that, Meredith, I'll turn over to you for any final closing thoughts.
This is Meredith. Once again, I want to thank you all for joining us for today's webinar. We will be sending out information about later webinars for PCMH. If you have any questions about this, feel free to contact me at meredith.gonsan, Gonsan, @tn.gov. And I look forward to hearing from you all in the future.
And this is the next one that we'll get to you the date in October on patient health management. And then here's my information as well. Feel free to reach out to me anyway. And with that, I think we're good. So have a great rest of your day. Thank you so much. And it's been great to spend time with you.